Hi, I'm Wendy Nilsen talking to you from the National Institute of Health. I'm in the Office of Behavioral and Social Science Research, and you might say, why is our office interested in mobile health? Well, all of NIH is interested, but the Office of Behavioral and Social Sciences Research is especially interested because everything mobile has to do with treatment, diagnostic screenings, measurement has to do with behavioral and social sciences, and thus it's an area we're really excited about. And at NIH, I must say, we really like to think about mobile in a broad way. So we don't cut it into little pieces and devices. We include sensors, all the way from nanosensors all the way up. We also include monitors, some of which are on the market, some of which have been created specifically for research. And finally, cell phones. Cell phones are amazing computing devices and can be used for many ways in mHealth. And the other reason NIH is really interested in this is because we see a lot of hype. I mean, I believe in mHealth. I think if you're watching this, you're probably really interested too. But there's a lot of hype, and we really need productivity. And for me, that'll come from the science, and that's why NIH is interested. So we think of a continuum of mHealth tools, and there really is across the continuum, and these are not discrete categories. We go from measurement all the way up to diagnostics, to treatments, and to global. And not that diagnostics, measurements, and treatment aren't global, but always keeping the global in mind because there's a lot we can learn from our global environment. So when we think about measurement and assessment, I'm just going to give you some examples of ideas in NIH that we've been working on. So we have stress hormone detection. In the past, we would swab people. We would have to time it perfectly. Now we have wireless stress hormone detections. So now we can see in real time how stressed people are. It's marked, it's coded, it's really a fabulous way to do it. We also have wearable chemical sensors. We know that not everywhere has the same exposure to chemical, like if there's a disaster. We know that it varies by where you are. So with the wearable chemical sensor, we can now see what's your personal exposure. We also have diagnostics. And we have things like Lucas. Lucas is a $2 lens clipped onto a microscope, and you can see it's very small. And right now it's in trials around the world, but it led us to really intensive microscopic work at a very low cost, so it's sustainable. We also do implantable biosensors. We're really working. Diane Burgess at the University of Connecticut is looking at one. It does multiple analytes. Now we can use these to track chemicals in your blood as they're going through instead of just measuring here and there. When we got treatment, we can do body sensor networks. This is the NOMI networks from Donna Sprouts at USC. And we can use these sensors, we can put them on children, they can give feedback, they can make aware, they can help children not spend their day on the couch, but be stimulated to get up and to do things, and that'll help us avoid an obesity epidemic. We also can do chronic disease management. We know the burden of chronic disease is huge, not only in the US, but also around the world. And so we know that most of chronic disease management happens in your real life when you're outside of the doctor's office. This is CHESS. It's from Dave Gustafson's lab at the University of Wisconsin. And this tool lets people know information about their disease, prompts them when they need to do things, and generally provides a lot of support between the patient, the caregiver, and the provider. We also can think globally, and again, all of these things apply globally, but global is such an amazing place for mHealth. As you all know, wireless has leapfrogged a wired system. So we really need to be thinking about that, and we also don't have a developed medical system in much of the world, and mobile will lead the way there. We can do adherence monitoring. This is Jessica Haber's project in Uganda, and you can see they've created a device called My Wise Pill. That each time that this woman picks a pill out of her HIV medications out of the box, it immediately registers. So you can see, is she taking the pills every day? Is she taking them at the time she does? And this is critical in HIV, where missed medication probably means the difference between a really long life with a chronic disease and death. And we can also use it for adverse event monitoring. This is in Peru, Walter Curioso, doing a really interesting job of having when women come in, they get medication, or patients come in and get medication, they can use this interactive voice response system so that they can say when they're having problems. Think about how wonderful it is to have a computerized database of when there's problems with medication. So there are some challenges, there are some funding issues with this, and I really want to talk about them. First, technology development. You all know things move quickly. At NIH, they move a little slower. That's because peer review is really important and it takes time. But we need to think about that. We also need interdisciplinary research teams. We have to build them. We haven't done that before. Before we've had a lab, and that's the way it's worked. And in mHealth, we really need to partner with our friends in medicine, our friends in engineering, and our colleagues in computer science. We also need new research methodology. We're going to have tons of data, but we really need ways to analyze this, think about missing data, and really work with it. We also have NIH study sections. We're looking for grant reviewers at this point. It's important to think about these things because we have new technology, new skills, and they're sometimes new to the NIH. And then we have IRBs and HIPAA, which an IRB is an institutional review board in the US, and then around the world. Those are really important for our research, but also teaching them about how do we do this technology? How do we keep people safe? How do we make sure that we're really balancing problems versus benefit to our participants? In the US, we also have HIPAA to consider, and that really deals with patient privacy and security. And of course, that's something we're all concerned about, and we're learning about and working with in mobile. And finally, getting to know with who to talk at NIH. That we do have NIH web pages devoted specifically to mHealth. Please search under NIH OBSSR mHealth, and you will find a lot of information and a lot of connections. So one thing I talked about before was the speed of trials versus the speed of NIH research versus the speed of technology. And people have said randomized controlled trials are too slow. We all know they're the gold star in medicine, but are they going to be the gold star in mHealth? And what I'm going to warn you is don't throw out the baby with the bathwater. We really have a whole lot of different kinds of testing we can do in mHealth, and we've had it in all the rest of medicine, but I think we need to really think about it in mHealth. Randomized trials are not the only way to do things. We can, early stage, do pre-post testing. We can do an N of 1 trial, which I'll show you a diagram of. And we can do interrupted time series. Here's a picture of an N of 1 trial. They used to be called ABA designs. But, we can take one person. We can add an mHealth intervention, or we can add an mHealth measurement. We can see what happens, and we can take it away, and where we can start it with adding it. But we can really see what happens at a single person level. In an interrupted time series, we measure a lot. We measure again and again and again. Perfect with mobile, where we can collect data, all the data we need. But in an interrupted time series, we see what happens when we intervene because we've been measuring all along. We can also do randomized control trials, obviously, but we can do things like step wedge. We can also do regression discontinuity. Here's a picture of a stepped wedge design, and I think that these are something we really need to think about in mobile, where we can scale quickly. But in a stepped wedge, we randomly assign communities, blocks, schools, whatever it is, and then we add the intervention, one community, block, or school at a time. In regression discontinuity, we pick people based on where they are on a regression line. And then we look at what happens after we intervene. Does the line change? Does the pattern that we were expecting to be there change? So again, it's an interesting design and great with lots of data. We can also do alternative to randomized designs. We've been learning from engineering, and there's new factorial designs, new fractional factorials, and also adaptive designs. And this is Linda Collins' multi-phase optimization strategy. And you think about it, we're always trying to optimize. We're always trying to get the maximum research for what we're doing. And in the most design, we screen components. We don't add them all at once. We screen them. So we go through, we screen them, and then we know what do we need to put together to make it work best. This is an example of a fractional factorial. You don't have to do every single component. As you know, we often add multiple things. So we're text messaging. We're also adding feedback. We might be doing calls from a provider. In a factorial design, we can actually look at each one of those components separately. And I encourage you to read the literature on this. We can also do a SMART trial, which is a sequential multiple assignment randomized trial. And this is Susan Murphy's work. And it's really amazing because it's much more like we practice medicine. So what we do is we design a study where we randomize people initially. And instead of saying you're going to be in your condition for the rest of the study, we say, if you are in a weight loss trial and you've lost 10 pounds, at the point where you lose 10 pounds, you will be randomized to another condition. So maybe you'll be in a maintenance phase. Maybe now you'll be in an enhanced phase. Maybe you won't get anything at that point. But we can now do it more like we practice medicine. But because it's randomized, we can really look at some of the effects. And here's an example of SMART. You can look at what the people's behavior is and really adjust the trial based on that. If I told you a lot about methodology quickly, and sometimes it makes people's heads spin, look at our website. We did a workshop on mHealth evidence, and the entire thing is videotaped. So it's a wealth of information, and you can see the experts doing it. And then again, that's on OBSSR's website. So please look for NIH and OBSSR, and you'll find us, look for our mHealth evidence meeting. So next steps. What are our next steps here? Well, think about it. We may think that randomized trials are really slow, but if you think about it, mobile may help that. We really think that the extensive measurement, the ability to do predictive modeling, so we'll have enough data that we can really model what we expect to happen. We can do real-time analytics. Now on a phone, we have a mini processor to work with. We can encourage treatment adherence. Sometimes trials have to stop because people aren't doing what you want. Well, now we'll know it, and we can figure out what to do about it. We can use non-invasive measures, so perhaps we can really decrease the burden on people. You can think if you can measure people's steps, or you can measure what they're doing based on a sensor where they don't have to input data, that's great. And then remote interventions may actually enhance recruitment. I know in the US, we often find that we recruit people that are near academic medical centers. And so now with mobile, not having to have people present all the time, perhaps we can make sure that everybody can be involved in research. NIH supports a lot of mobile health research, and I've listed one here, PA 11330, and that actually targets mHealth, but don't ever let that stop you if you don't see it. NIH really loves your great ideas, and even if we don't specify it, we have these things called parent announcements. I have them listed on the screen, PA 11260 to PA 11262. These are for your brilliant ideas. This is for your wonderful science. And if mHealth is your wonderful science, bring it in. NIH also does training institutes, and I'm really very proud of those. They really help us bring together multidisciplinary teams to do the kind of science we need to move mHealth forward. This year, our Summer Intensive Institute will be at UCLA in August, but we also do additional 1- and 2-day training, so please check on our website. And finally, NIH has a listserv that's devoted specifically to mHealth. I have the listing here. If you are interested in joining us, please join us on the listserv. And also, if you have ideas to be distributed on the listserv, I'd love to hear that from you. So with that, this is all we have on mHealth at NIH. Thank you.